Let's go, guys.
Bom dia a todos. Gostaria de agradecer em nome da Sociedade Brasileira de Ombro e Cotovelo e da nossa regional, o Norte e Nordeste. Hoje nós vamos dar início ao nosso primeiro webinar, né, dando sequência a um programa que já foi iniciado em 2020, sob a liderança do nosso amigo Fábio Brandão. A gente teve a missão de dar seguimento a esse projeto que foi exitoso no ano passado, e para esse nosso primeiro encontro, nós teremos conosco aqui o Dr. Jean Kany, né, que já esteve conosco no ano passado, um colega de muito apreço e sempre disponível, que esteve ao nosso lado e com excelente conhecimento, um ótimo cirurgião, com grandes publicações, e que se dispôs a estar aqui nesse nosso primeiro encontro. Good morning, and Dr. Kany, it's a pleasure to stay with us for the first meeting. The last year, we have you with us, and it's a pleasure the next time and the first time stay with us. We have with us our president of our main society, SBOC, Dr. Adalberto Visco. It's a pleasure to stay with us. And Dr. Luiz Alfredo from Bahia, Dr. Fábio Brandão, they are the president for the last year, and the another doctors stay with us in the second part of web meeting. And Dr. Adalberto Visco, do you want to say anything for us? It's a pleasure. Good morning, Dr. Adalberto. Estamos às suas ordens. Obrigado por estar conosco nesta manhã, nosso presidente da sociedade. Nós estamos à disposição para ouvi-lo.
Bom dia a todos vocês. Muito obrigado pelo convite. É um prazer, eu sempre digo que participar dessa reunião da Regional Norte-Nordeste, para mim é um prazer. Eu que modestamente fui um dos fundadores, junto com o Dr. Glauco e o Dr. Saulo, dessa sociedade, e ver ela crescendo, sempre atuante, é um prazer muito grande. É um prazer muito grande ter olhando aqui o Dr. Osvandré Leque, nosso presidente do board, muito obrigado. Fora isso, um grande amigo de todos nós do Nordeste. Good morning, Jean. Thank you for your pleasure for stay with us here. And pleasure this webinar. It is available in the Saturday morning here in Brazil, is in afternoon in French, for updating us for this topic. Thank you very much. It's very pleasure for us. And good class, good lesson. Thank you.
Thank you.
Osvandré, quer falar alguma coisa?
Yes, please. We have some words from Osvandré. As Dr. Adalberto said, it's an honor to have a so special guy in our Brazilian society. Dr. Osvandré is an inspiration for lots of surgeons around Brazil, and it's an honor to have you here.
Yeah.
Bonsoir, Jean.
Salut. Salut. Bonsoir.
I wish to be able to speak in French.
Yes,
I almost learned. Sure,
Oh.
I tried.
Okay.
but then it was so difficult.
Really?
And sorry to welcome you in English. I know I should do this in French. Jean Kany is a longtime friend of us. He has done marvelous things in shoulder surgery, not only in France, where he's a leader, but worldwide. And to hear him to talk about such a difficult subject, AC joint reconstruction, with the arthroscopic method. It's such a nice thing to do in this Saturday morning where the whole country of Brazil is in lockdown right now. We are having a very limited period of life because we have to knock down this pandemia as soon as possible. Jean, always great to see you.
Thank you. Thank you very much. Thank you very much, Osvaldo.
Okay, Diogo, let's go.
Vamos começar. Start.
Vamos começar, dar início à aula do Dr. Jean Kany na primeira parte e nós iremos abrir para perguntas. Quem tiver alguma pergunta, por favor, nos enviar através do chat, tá? E ao final nós iremos transmitir as perguntas ao Dr. Jean Kany e na segunda parte nós teremos uma mesa redonda com a presença do nosso amigo José Carlos Vilela, que é conhecido como Zeca, lá de Minas, né? Que se dispôs a estar conosco aqui. E nós teremos a participação do Felipe, né? Do Sérgio e também do nosso colega Rodrigo, lá do Maranhão, tá? Na segunda parte, onde nós faremos a discussão dos casos. Dr. Kany, the time it's yours.
Okay, so I share the screen, okay?
Okay.
I do. Is it clear for you?
Yes.
Okay. So again, everybody, thank you very much for this very kind invitation. And it's a pleasure for you, but you have to know that it's an honor for me to share my experience. And as I've told already previously to everybody, we have some answers, but we have a lot of questions too. In fact, I would like to share my mistakes. And in France, we call this the dialectic. And dialectic has been created by Hegel, French philosopher. So, also, I don't know why I have problem with my slide. I have this is my disclosure. I am consultant with VIMS, FH Orthopedics, and my tech too. So, if you want to have a good answer, first of all, you have to ask good questions. So, first question regarding the AC joint is: do you really need to take a surgery? And if yes, why do you propose an arthroscopic procedure? Because you can make it open. And I would like to explain you what technique I stopped. And I would like to talk about the acromioclavicular stabilization in addition to the coracoclavicular stabilization, and would like to discuss about the distal rotation of the clavicle. So when you see what happened, of course, the instability is not only vertical, and this is a very bad animation because you can see that the clavicle is going up, but in fact, all the shoulder is going down. And I think you have, of course, vertical and horizontal instability. That means you have a rotational instability. Vertical plus horizontal means rotational instability, and this creates very difficult problem. So I don't think the classification of Rockwood is really logical, but I think we have two things to understand before to take a surgery. First of all, sometimes your dislocation is unreducible because you have soft tissue interposition. And sometimes you have a posterior displacement of the AC joints. And because of that, I think it's mandatory to ask for a CT scan to understand where is the dislocation and why you have some impingement. If you discuss with American people, 80% of the Americans disagree of taking a surgery. But you can find some publication like that, and especially the one of Pascal Boileau, and they show you that 20 to 40% of the people have some symptoms after the surgery and need to take a surgery, need to take a surgery in a chronic situation. And you know, like me, that the chronic situation is more demanding to repair than an acute case. It's easier to repair an acute fracture. It's more demanding to operate a malunion or a non-union. It's exactly the same for the dislocation of the AC joint. Sometimes you have to take a surgery, but look at this patient. In fact, first of all, it was not a dislocation of AC joint, but a distal clavicle fracture. But this patient had no pain and she did not ask for a surgery. The problem was something else. So sometimes you don't have to ask for a surgery. But sometimes patients come with symptoms. They can have, it's possible to have some pain, discomfort, crepitus, and sometimes there is some aesthetic problem and you have to treat them. So this was the first point. So now, why the second question is open or arthroscopic? Of course, I did it open for a long time ago. But when you make it open, you know, like me, that it's very invasive, first of all. And the problem is aesthetic too, but it's possible to do it. I did it a lot. But when you make it arthroscopically, you have a better vision of all the shoulder. You can check the AC joint. You can check under the clavicle, under the correct process. You can take the graft of the CL ligament. You can control everything. And this view is just impossible to be seen in an open technique. So I think the arthroscopic technique is better, can be better, but the problem is it's more demanding, of course. So what did I stop now? And I would like to show you what I stopped. That means I did it, but I stopped. I stopped the car wires. I stopped the tension bands. I stopped the screws. And I stopped the wraparound Coracoid process. And this can be discussed later with you, of course, my friends. But why did I stop, for example, the car wires, the tension bands, and the screws? First of all, the Chi wires, the tension bond, is not very logical because you create a stiff shoulder. Sorry for it's too quick. You create a stiff shoulder, and the AC joint is a joint. It gets some movement, mobilization. If you fix it with tension bands or Chi wire or screws, you create a stiffness, and I think you cannot have a physiological repair of everything. And I stopped this technique a very few years ago, very long time ago. I did a lot of wrapper coracoid fixation, the U-shape fixation, but look at what happened 20 years ago. If you wrap around the correct process with a synthetic ligament, you may have a lot of risk of failures. Look at this patient. Of course, the reduction was not so bad, but with time, he had some impingement with the skin and the device, and there was two problems. First of all, there was, of course, a rupture of the device. It was a wraparound around the Coracoid process, but there was an impingement with the skin, and you can see here a few years later another patient. Again, you remove the ligament because there is a friction. So the problem is not the tear but the friction, and because of that you may have some impingement. So now I would like to ask you a question. This is another question. We can imagine, of course, a transclavicular and transcoracoid drilling, and today probably it's a very very classical technique. This is an example with, of course, a good result. But is it the best one? Is it the best technique? When you read publications, you can see lots of complications. Look at in these papers, you can find 20 to 44% of complications, and you have to understand why. One of my answer is, in fact, it's not really anatomic because you just repair with a single bundle technique, and it's not really physiological. You just reduce the vertical instability, but you do not control the horizontal instability. And you have a late complication. Look at this publication. A few years later, you have a risk of having a clavicle fracture at the position of the tunnel. And maybe in the past, we drill with two big drills. And in this publication, it was 4.5 diameter drills, and probably it's too big. And with time, you may have this risk of having a secondary fracture of the clavicle because it fragilize lots of things. So what could be the answer? I don't have the answer, but what could be the answer? My daughter was in first years of medicine a few years ago, and she showed me this draw, and I realized that she learned, of course, the anatomy. And when you look at the anatomy of the AC joint, you have 3 ligaments, and you can understand what is the mobilization, the range of motion of the AC joints. You have 3 ligaments, and maybe if you want to expect good results, we have to make a reconstruction of the 3 ligaments. And maybe lots of techniques are not anatomic enough. So what is the normal anatomy? Where to drill the tunnels? And if you look at this publication, you can see that the trapezoid ligament is at 22 millimeters from the AC joint, and the conoid ligament is at 48 millimeters from the AC joint. But it is an Asian publication, and maybe in another country in the world it's different. But this is one of the first paper. This is another paper coming from Korea. It's exactly the same results. You see, 22 millimeters from the AC joint if you want to drill laterally, and 48 millimeters if you want to drill medially. And this is our study in Toulouse, because we've imagined that maybe for the Asian people, it's not the same that for the American people or the European people, maybe in your country in South America is different. So the goal was to understand what is the best point to drill for the conoid tunnel. And we made lots of CT scan. This is not published yet, but it's just a French presentation. But we have shown that the good positioning of the conoid tunnel is at 27% of all the length of the clavicle, and this is reproducible regardless sex, ethnic, waist, and side. And this could be maybe a good anatomic landmark to recreate the anatomy, because you can see that we can see perfectly the conoid ligament. And now, how to drill the coracoid tunnel? Where to drill? We have already read this paper, and you can see that the best drilling for the coracoid process, if you want to drill, is 32 millimeters. That means as posterior as possible. As posterior as possible means sometimes if you are too anterior when you drill, you may have a non-anatomic reconstruction, an anterior translation of your clavicle, and maybe a bad result. And the second point, if you drill too anteriorly, you may have a fracture of your coracoid process, and this could create, of course, some problems. So to sum up the drills regarding the clavicle and the coracoid process, I think, but this is my personal point of view, in case of dislocated AC joint, you have to drill both clavicle and coracoid process separately to be anatomic. And I disagree with my colleagues who use a guide, because with one guide, sorry, I come back. With one guide, you are supposed to be exactly at the perfect position onto the clavicle. You have to be perfectly at the good position through the coracoid process, and you have to reduce the AC dislocated joint. And I think it's not possible with a simple guide to make 3 different steps in the same time. Because of that, I prefer, and I will show you my technique, I prefer to drill first the clavicle because it is dislocated where I want at the anatomic point. I want to drill where I want the coil process at the atomic point, and then you join it and you reduce everything. So this is an animation to show you how I do. So the two drills are made without any guide. This is my point of view again. Maybe it's more demanding, but I think it's less risky than with a guide because, again, for me, it's impossible to make 3 steps in the same one procedure. But if you drill separately both bones and then you put 1 or 2 ligaments like that, it's easier and you have less risk of having a problem and, for example, a fracture. So what I propose today is to make a triple ligament reconstruction. So I will show you. I put 1 adjustable loop ligament at the medial tunnel. I graft the lateral tunnel, and I put a tension band, but with a tape tension band around the AC joint. So it was not possible for me to show you with a beta draw, so I drew it yesterday night for you, but it's very easy to understand. This is the first step. You drill both tunnels through the clavicle at 2 centimeters from the lateral aspect of the clavicle and 4 centimeters. And you drill with 2.4 millimeters. So it's a very small drill. It's not 3, it's not 3.2, it's not 4. Then you cut the AC ligament and you harvest for the graft. Then you drill the Coracoid process with a 2.4 millimeters drill. Then you implant your adjustable loop through the medial tunnel. Then you graft the lateral tunnel, and at the end you put a tension band, or you make a cerclage around the Coracoid process. And you will see here arthroscopically how I do that. So the first step is to prepare the AC ligament, and it is clearly for me the most demanding step because you are just under the skin. Here we are just under the ligament, and you have to make the dissection, but you don't have to cut it. Then you can see that this ligament is very large, like a tape, and it's always horizontal, more horizontal than you can imagine. Then with a needle, I loop and I make a triple Krakow suture through this AC ligament close to the acromion with number 2 suture. And this is, again, you need 4 hands with my assistant, but it was very, very demanding for me at the very beginning, and now it's just 5 minutes for me, but I wasted a long time, many years, many hours, sorry, to learn for that. And if you do that, you will have no risk. You have no risk of tear or rupture. It's very efficient, very strong, but I think this is very important. So now you have to look for the Kirchner wire because you've drilled the clavicle previously, and through the tunnel from the clavicle, you have to control that your tunnel are through the bone. You have to control that you have enough bone in front of your clavicle. And then you drill the Coracoid process and you introduce a loop 2. We are under the Coracoid process here. You take your loop, and now everything is ready to make the triple repair. So this is the adjustable loop through at the inferior surface of the Coracoid process. This is the superior surface of the Coracoid process. And then the goal, of course, is to introduce this loop through the medial tunnel of the clavicle. This is the medial tunnel of the clavicle. This is my adjustable loop. Now, with another loop through the lateral tunnel. You take the green suture, which is, you remember, the graft, and you introduce this graft through the lateral tunnel. So it is a river and then procedure, and you can see how easy it's possible to reduce it. And at the end, I put another button at the distal surface and inferior surface of the clavicle for my acromioclavicular cerclage. This is the last view, just under the clavicle, and this is what I am doing today. What are my results now? Okay, this is one case. You can see the double low plus, so the result most of the time is good, not so bad, but as you will see, this is my result. I would like to show you my evolution in time. Between 2005 and 2013, I had about 120 patients, and at this time, I made the wraparound Coracoid technique, a U shape. I drilled with 4.5, and the rate of failure was about 1 patient out of 2. So I was not really happy with that. It was an open procedure first, and even after having switched to arthroscopic technique, because it's possible to make arthroscopically, I was not very happy with some rate of infection, clavicle fracture, and lot of revision. Between 2013 and 2017, I've operated 38 patients, and it was a single bundle technique procedure. I drill small 3.5, and the rate of failure was 11%. So it was better, but not perfect, with sorry for this problem of slide, some case of coracoid fracture or button loosening or capsulitis. And since 2018 to 2020, I use a double band technique, the technique I've shown you, and the rate of failure is smaller, 3%, with only the problem of malreduction. Sometimes it's not perfect. Look at this patient. So it's not so bad, but with time you have a widening of the tunnels, and you can lose your reduction with time, because probably this is one of the problems. You lost your reduction, and this is not clear for me today. This is another problem. It is the limits of the double bond, and you can see this paper from our friends, Korean people. So the double bond is very okay to control the vertical imbalance of the shoulder, but it's not perfect to control the horizontal balance of the reduction. It's not perfect. And because of that, I think if you want to be perfect, and if you want to have a perfect reduction, you have to fix first the vertical plane and the horizontal plane. And I believe and I follow my German colleagues, Markus Scheibel, Matthias Jumstein, Mark Tober, when they explain me that you have to fix the AC joint. I think they're right. You have to fix the AC joint in addition. I think it's very, very important. And this is what you have to do when you have an interposition, because if it's not possible to reduce, it's very easy arthroscopically to control your AC joints, but you have to release it, and this is mandatory for me today. You have to control the AC joint. So in conclusion, I think you have 3 points to remember. First of all, if you want to be anatomic, you have to reduce, of course, both horizontal and vertical plane. And I think you have to imagine something around the AC joint in addition to vertical plane. The second point, if you can make 1 or 2 ligaments through the clavicle, one or two ligaments. I think two are better than one in my experience, but the high risk is to having a clavicle fracture. So if you drill too big, more than 3 millimeters, I think it could be risky. So if you drill with very small diameters. And last but not least, I think, especially in clinical cases, you have to graft with the AC ligament, and this is my routine technique today. So thanks again for your very kind invitation, and the Le Mans shoulder course, the task, and I call this the 24 hours of Le Mans shoulder, will be held in Toulouse in 2022, and I think we'll have some guy from your country who will participate with live surgery in this great event. Thank you very much, my friends.
Thank you very much, Dr. Jean. And now we open to ask for our audience. Pessoal, nós iremos abrir agora para perguntas. Por favor, utilizem o nosso chat para fazer perguntas. Eu vou iniciar com o Fábio e nós já temos algumas perguntas aí no nosso chat.
Jean, outstanding lecture. Congrats to you, as always. My question is, we know that one of the main advantages when you use the scope to do AC joint dislocation repair is for us to see associated lesions that we might have in the shoulder. We have some articles. Scheibel showed us 30%. Burkhardt showed us 50% of associated lesions with the AC joint dislocation. So in your practice, if you go into the shoulder to repair an AC joint dislocation and you find some cuff tear or some labral tear, some slab tear, do you repair it at the same time, even though you might get this shoulder stiff in the post-op?
So very good question, Fabio. Thank you. In fact, to be really honest, because we were together, no, it's a joke. To be really honest, I don't see a lot of associated lesion. I know, of course, Marcus, Matthias, all my friends. Most of the times, patients are very young. So when they are very young, we do not find a lot of cuff tear. You may find some slap lesion, but it's very rare. One of my patients, I've made a Latarget, arthroscopic Latarget a few years ago, and he made an AC joint dislocation after. I go, of course, through the shoulder, and there was no damage into the shoulder. The problem was not the AC joint. I do arthroscopically because I think it can be better. It can be better to view the AC joint, to control the inferior surface of the clavicle, to make a more anatomic reconstruction and a less invasive surgery. I do not practice the arthroscopic technique because I think about possible combined lesion. But to answer to your question, yes, if I find a combined lesion, a cuff tear, a slap lesion, yes, I repair, yes.
Thank you, Jean. We see.
Dr. Kany, I'd like to have a question. It's a pleasure to have you here again, and great presentation. And I'd like to know about the diameter of the buttons. You actually are using a tunnel with 2.4 millimeters, right?
Yes,
and
correct.
What about the diameter of your bottle?
The diameter I have two buttons. The first one is 7 or 8 millimeters. I'm not sure about that, between 7 to 8. 7 is the minimum because it was a discussion with Wim's company, who is my partner, my company partner. So the small one, the regular one is between 7 to 8 millimeters of diameter. And the revision one is 14 millimeters. In case of revision, or if you have a fracture of your clavicle, or if you have a widening of your tunnel and you want to make a revision, we have a bigger button, but right now I didn't use it. Okay. The big one.
Dr. Kany, we have a question for Dr. Sergio Kekia. It's our main chief of our and book, and it's the what do you think about biological use on the AC joint and the repair of the AC ligament superior AC ligament? What do you think about it of biologics and AC ligament superior?
So, for the first question regarding the biological repair, of course, it's a good idea. And for example, the Mazoka technique, which is made first open and it's possible to make it arthroscopically. So Mazoka technique, in fact, I think you need a graft. So if you can use an allograft, why not? But in France, for example, we have no allograft of ligaments. I don't want to use arm string if it's not mandatory. I use the Mazoka technique, the biologic repair, in case of revision after lots of failed repair, because yes, at the end it works very well, but I make it open. The problem of a Mazoka technique or Mazoka of a graft, for example, you have to drill with very big holes and tunnel through the clavicle, minimum 4 millimeters. You have to drill 4 millimeters and you have to put interference screw. It's very big, and I don't, as you know, I don't like making too big holes, and I don't like this technique because of that. You can wrap around the correct process with a graft, but I show you a lot of failures with not a biologic graft, but with tapes. I don't like this technique. In fact, this is the first answer for the biological reconstruction. For me, only in case of revision and an open technique. Why open? Because the most demanding step in the arthroscopic technique is not to do what I've shown you, is to drill. It's very difficult to drill and to be perfectly at the central part of a clavicle. Most of the time you are too much anterior or too close from a cortex. And then if you use a very big drill, you may have a fracture. So if it's open, of course, it's very easy because you see the clavicle and you can drill without any risk with a 4 millimeter drill. The second question regarding the superior ligament reconstruction, of course, as you can see, I do a cerclage with a tension band. Now it's my new technique, but our evolution is to go with a superior reconstruction, with an arthroscopic superior reconstruction with tapes. Yes, I think it's a good idea.
Nice.
Thank you.
Diogo, we have a lot of questions regarding the post-op protocol that you use. We have a question from our current president of the Brazilian Shoulder and Elbow Society, my good friend Márcio Cohen, regarding the type of immobilization that you use. If you put a regular sling, or
yes,
you put an adduction pillow to
Let's combine the question.
Yeah.
Besides this, from the audience, they asking when you started the physiotherapy.
Yes, of course. 4 weeks. 4 weeks is the waiting time before starting the physio. And I use a regular sling. I do not use an abduction one. I think an abduction one is useless because the problem is the weight of the arm, and you just have to help the healing with a regular sling. But every day the patient can remove his sling and he can make a personal pendular mobilization. But the physio really starts after 4 weeks. And after 3 months, I consider the healing is done.
Zeca, do you have some questions?
No, I have no question. It's a great lecture. Congratulations on your presentation.
Merci.
Dr. Kany, we have another question from Sandro Reginaldo from Goiânia. What do you think about your first technique? You think that's about your curve of learning, or thoughts about technique? and when you change your technique?
It means, can the bad results of his first case series also be credited to the learning curve?
Yes, I understand the question. No, it was not a problem of learning curve. The first technique, it was the wraparound ligament under the correct process, a U shape. This was my first technique. I made a lot of cases open, and it is very easy, but you don't see anything under the correct process, and I didn't have any complication, perioperative complication. And I've switched a few years later under an arthroscopic technique, and I've published this paper with my failures. The problem was not the learning curve. The problem is a problem of biomechanic. When you use this ligament, and the manufacturer says it's very strong when you test the ligament in the laboratory. But in fact, the problem is not there. The problem is the friction, because this ligament slides under the correct process, and because it slides, there is a friction, and the friction is the main cause of the failure at 2 or 3 weeks of this system of reconstruction. I don't think the wraparound is a problem. I think the problem is the friction under the wraparound, under the correct process. And I have to confess you that we are working on a new system of ligaments, artificial one, not a graft, which is possible to go to wrap around under the correct process because it's very easy and very safe without with prevention, but we are going to prevent the risk of friction of this ligament. So the problem was not my learning curve, the problem is a biomechanical problem, and I think we have found an answer for this problem, for this point.
Very nice. We have a question for João from Natal.
Dr. Kany, congratulations. And I have one question. In the Rockwood classifications in tip 5, when we have a disruption of a fascia deltotrapezoidal, yes. Do you change your surgery for these situations, or it's the same surgery?
No, it is the same. For me, again, and it's very difficult for me to discuss with everybody with a Rockwood classification, because, in fact, I do not really understand the Rockwood classification, but I know the type 5 that you asked me. Whatever the lesion, it's always the same technique. For me, there are only 2 different possibilities. Either the dislocation is possible to be reduced under total general anesthesia. That means there is no interposition, and I make the technique I've shown you. Either it's not possible to be reduced because you have a posterior dislocation or you have a soft tissue interposition. This is very frequent. In that situation, it is exactly the same technique, but you must release the AC joint, and you have to see what is interposed, and you have to release the joint, and then you can make the same technique, and the results are the same. The problem, so far, for me, the problem was, few years ago, I was not able to control the AC joint, or I thought it was not mandatory. I was very happy because I implanted the ligament through the clavicle and through the correct process, and I thought it was enough. It was a mistake. You have to implant your ligament, and of course you are very happy, but you have to assess or to control the AC joints by an arthroscopic control, and you have to release everything. For me, this is the difference between the 2 big states of Rockwood, but the state 3, 4, 5 of Rockwood for me doesn't mean something very clear.
I have another questions with the meeting. It's a questions about this. It's possible to do this technique in the lateral decup position.
I cannot answer because I make it in the B-chair position, but I think honestly, it should be difficult. It should be really demanding because you have to bend in front of your patient. Maybe it's possible. I think it's possible to put a ligament from the clavicle to the coil process in the lateral decubitus position. But making a real Weaver head-on procedure, I think it is probably difficult. To harvesting the AC ligament, it's difficult. So in a lateral decubitus, I'm not sure. I don't say it's not possible. I'm not sure.
Jean, we have a question. We have a question from our friend. A question from our friend Jai Simer from Vitória. He's asking about new fiber anchors with the smaller holes in the coracoid. Do you think it's an option? And he's also asking about the AC ligament repair. If you have any comments about acromial hole positions and risk of fracture, vertical and horizontal. Is there any biomechanical issue?
Excuse me, Fabio. Could you repeat the two questions?
I think some part of the questions it was presented in the presentation. The answer was in the presentation. I think the first question is okay. What about new fiber anchors with small holes in the coracoids? Do you think it can be an option?
New
fiber anchors.
New fiber anchor
with small holes in the coracoid.
You just put one anchor through the coracoid and then you repair. Yes, I think it's possible. I think it's a good idea, but I've imagined something like that. Yes, to prevent any tunnel through the coil process or to prevent the wraparound process, we could imagine, of course, an anchor through the coil process. If it's strong enough with tapes, you can turn around the clavicle. I think you have to imagine something very stronger onto the clavicle, but of course we have some implants, trial implants like that. Yes, I think it's a good idea, very good idea. Yes, of course.
Nice.
And the second question, it was for the AC joint?
No, yeah, when you do the AC ligament repair, any concern about the risk of fracture in the acromial? Do you think there's a better option to position?
In the technique I've shown in the video, I turn around the acromion, the spine.
You don't drill it.
So I do not drill. But now we are working with a special guide and a very small drill and very small implant to be more precise and to have no problem in the acromion. But of course, I am afraid about a fracture in the acromion. Right now, I do not drill, but we're working on.
Osvandré, do you have some questions?
Merci, Jean.
Merci.
Perfect conference. Well, teach us once again, how you fix the AC joint horizontally. That I miss it in your very nice presentation and drawing. It's very clear to me, the vertical fixation, but that trick is new and maybe some other colleagues would like to review again.
So thank you, Osvandré. This is the point of my presentation. You're right, and it was unclear, and I confess that. I agree with you. It was just impossible for me to make a very nice movie regarding this step, because at the end of the surgery, after 1 hour, you have a swelling shoulder, and you don't see a lot, and it's not precise enough. So, of course, I'm sorry, but my video was not precise enough. But what I do is I turn around right today. So far, I turn around superficial and to the deep surface of the acromion without any drilling, and I loop the acromion with tape, and this tape is fixed thanks to a button at the inferior part of the clavicle. This is what I am making today, but we're working again on a new system of very thin ligament to fix it with very thin tunnels at the superior part of the clavicle. So we are in a evolution right now. I cannot show you.
And then you will build the superior AC ligament as it was.
Yes. This is the goal. The goal is to fix the superior wall of the AC joint. Yes, this is the goal, and we are working on that, on this idea. It's the main idea of our evolution today.
Dr. Kany, Dr. Oswald André, muito obrigado pela pergunta. A todos os colegas que participaram e fizeram perguntas. Nosso webinar tem duas partes. A segunda parte com o nosso amigo Zeca, né? Reforçar e agradecer a presença do Dr. Adalberto, né? Do Márcio Cohen, presidente da SBOT, do Dr. Adalberto, Dr. Márcio, presidente da SBCOC, né? A presença do Dr. Oswald André, do Fábio Brandão, ex-presidente da nossa Sociedade Norte-Nordeste, Luiz Alfredo e João. E aí nós vamos passar agora para...
Dioguinho, me perdoe. Só para não deixar uma pergunta no ar, nós temos aqui uma pergunta do Paulo Henrique Silva para o Dr. Kany. Only the last question, Professor Kany, from Paulo Henrique Silva. He would like to know if you change the way you are going to the surgery, if the health insurance delays a lot of time to allow arthroscopic surgery. For example, arthroscopic up to 1 month from the accident open, if a month passes, or if you only do arthroscopy all the time.
Yes, the question is in French, so I can see the question in French. Thank you, Paolo, Enrique. No, I never open a shoulder except for shoulder prosthesis. So I never open an AC joint. I do it always arthroscopically. If the trauma is only from 10 days before the surgery, you could imagine implanting only the ligament, an adjustable loop, without any weaver and done procedure. But after 10 days or 2 weeks, or even more, 1 month, I make a weaver and done because it's not strong enough if you just repair, if you just put one ligament. So most of the time, I do not see the patient in emergency. I see the patient after 1 month or 2 months. So I always do weaver and done, arthroscopic, yes.
Okay, thank you.
I have just one more question. What does he think about the stabilization of the AC joint with the 2 anchors, like internal brace technique?
Like 2 anchors. So you put 2 anchors, 1 anchor into the acromion, 1 anchor into the clavicle, and you fix it. I think it's a very good idea, but I have no experience. But I will try. Honestly, I think it's a good idea.
Okay, thank you.
Yeah, one more comment before you go, Jean. Thanks for holding Neymar in France. Keep Neymar for many years ahead. You're doing good.
Well, okay, if you want. I do not control this guy.
we cannot control this guy, okay?
But in French, he's a superstar. Okay.
Thank you.
As I told you before, Jean, this is we have now the second part of the meeting. We will command with Dr. José Carlos Vilela. And if you want to stay with us, we can discuss in English too. That we know we are on Saturday, and feel free to stay with us or not. Okay.
Okay. I will stay with you. I will cut my mic, and if you want my opinion, I will be there. But I cut my mic. Okay.
Great.
Thank you again.
Yeah,
Thank you again, guys. Thank you very much.
Thank you so much. Thank you so much.
Okay, Zeca, please go ahead.
Palavra sua, Zeca. Vamos lá, meu amigo.
A imagem está certinho?
Tá.
Excelente.
Bom, eu gostaria de agradecer o convite. Eu acho uma iniciativa mágica, né? Uma iniciativa excelente que não é nova, vocês estão fazendo desde o ano passado. Esse projeto de educação continuada, eu fico bastante honrado em poder participar. Eu sou cirurgião de ombro do Hospital Mater Dei da Unimed, BH, e a minha equipe, o Lucas e o Thales, a gente tem uma sinergia muito boa. Meu para-casa aqui era apresentar uns casos clínicos para discutir com colegas da sociedade e de forma que a gente pudesse debater de uma maneira bastante informal casos do dia a dia. Então, eu selecionei 3 casos, por favor, você sinalize se o tempo estiver estourando, um caso muito frequente, um médio frequente, um menos frequente, mas que nenhum cirurgião de ombro vai ficar livre, vai ficar sem encontrar casos dessa magnitude. Então, vamos lá, vou fazer o primeiro, e aos colegas Felipe, Rodrigo e Sérgio, nós vamos começar bem informal, não é pegadinha. Eu queria discutir de colega para colega, tá certo? Eu vou coordenando por ordem alfabética, eu não tenho nenhuma predileção e nem o contrário com os colegas. Vamos lá para o primeiro caso. Esqueci, o Jean está ouvindo, né?
Ah, tá conosco.
N'exécuté pas, si vous voulez commenter, il faut parler avec moi, d'accord? Então, vamos lá. O primeiro caso é um homem de 55 anos, destro, ombro direito. A queixa principal dele é dor e incapacidade funcional. Ele foi previamente operado, supostamente pelo manguito, eu não sei, os exames também não ajudaram muito. E, além de todos os comemorativos de uma lesão do manguito, ele tinha bastante evidente o sinal da cancela. Então, essa é a radiografia. Vamos começar com o Felipe. Felipe, a radiografia não está espetacular, mas ela já dá indícios do que a gente vai encontrar pela frente. Você quer falar um pouquinho?
Oi, bom dia. A gente vê uma crônica clavicular realmente discretamente deslocada. É difícil ver nessa imagem de AP de ombro, né, verdadeiro. Seria o ideal um AP isanca, né, de acromioclavicular para poder fazer. Esse aí é um AP corrigido, então acaba atrapalhando um pouco a visão da acromioclavicular. No perfil, aparentemente não tem nenhum deslocamento maior posterior. E o que a gente vê também que chama atenção, acho que nessa articulação do ombro, é um pouco de ascensão da cabeça. Essa cancela positiva no exame clínico já leva a gente também a pensar em uma lesão do manguito, talvez uma lesão do manguito irreparável, né? Ele pode ter associado aí. Irreparável não, uma lesão do manguito extensa, né? Então, acho que é isso que dá para falar inicialmente.
Exatamente, é isso que dá. Eu queria pedir desculpa, porque o tópico era acromioclavicular, mas eu acho que a cereja do bolo foi o que o Jean Kany fez, né? Depois de mostrar a ressecção, a fratura, tudo ficou mais simples, e o Luiz me deu a liberdade de poder escolher casos que extrapolassem a acromioclavicular. Então, eu peço desculpa a vocês, eu não queria sugerir isso, mas você foi brilhante. A gente percebe que tem uma femorização da cabeça femoral, uma ascensão superior. Rodrigo, essa aí é a ressonância desse paciente. Você quer acrescentar alguma coisa?
A gente percebe no corte sagital, em T1, uma atrofia muito importante do supraespinhal. Parece ter também uma atrofia do infra, em menor quantidade, mas o supraespinhal bastante atrofiado, possivelmente o Talier 4. E corrobora com a imagem da radiografia, então é possivelmente uma lesão maciça e talvez até irreparável.
Esse é o exame, então, Sérgio, corroborando o que o pessoal falou. A gente está diante, clinicamente e radiograficamente, de uma lesão irreparável do manguito, né? Isso abre uma gavetinha das opções terapêuticas que a gente tem à disposição. Você quer falar, Sérgio, se esse paciente chegar para você, ele é relativamente ativo, o que você tem para oferecer para ele?
Esses casos assim, eles ficam até um pouco complicados, né? Paciente ativo, talvez você pudesse fazer uma transferência muscular. Mas eu, primeiramente, ele já tinha sido previamente operado, né?
Sim.
Eu, primeiramente, faria uma artroscopia, certo? E veria se conseguiria ainda repor alguma parte desse tendão. Se não, ia para alguma transferência muscular.
Felipe e Rodrigo, vocês concordam? Vocês têm outras opções? A literatura é bastante enxuta, né, com relação às operações terapêuticas, as opções terapêuticas para esse caso. Então, vocês também iriam de transferência ou chegariam a pensar na prótese reversa?
Não tem Porque fica difícil até porque não tem a imagem também do coronal, né? Para poder saber como é que está o supra ali, se está próximo, perto.
Não, eu fui muito direto, desculpa. É um PAT 3, é reparável. A qualidade do tendão e encurtamento são... igual o Rodrigo falou, é um Gutalia 4.
Gutalia 4, né? Realmente.
Por si só, o Gutalia 4 já é contraindicação, repara.
Já seria, exato. Então, assim, eu realmente ou ir para transferência muscular, né? Que aí pode ser grande dorsal, trapézio inferior. Então, realmente partir direto para a prótese reversa, porque aí ele tem 50, né? Qual a idade dele mesmo?
55 e relativamente 55, ativo.
Né? Acho que realmente a primeira opção aí seria a transferência muscular, né?
Ok. Jean Kany, would you like to add something? We are talking about a reoperated patient with a repairable cuff tear. What is your first choice?
Yes, I think I've understand the question and the case. This patient is 55, have been operated with a failed previous cuff repair, and there is now a fat infiltration of the supra and infraspinatus. For me, it's a very good indication for latissimus dorsi transfer or lower trapezius, but in this situation, I prefer the latissimus dorsi transfer.
Is there any special advice for choosing the latissimus dorsi instead of trapezius?
Yes, if you want to recover external rotation, I think the lower trapezius is better. But if you want to recover both elevation and lower external rotation, I think the lat dorsi is better.
Okay, thank you very much. I appreciate your help. Então, pessoal, tá aí o caso. O Felipe, Rodrigo, Sérgio, fiquem à vontade. Igual eu falei, isso aqui é uma discussão entre colegas, não é pegadinha, não é para apertar ninguém. Algum de vocês tem experiência com transferência? É um negócio que pouca gente no Brasil pode falar que tem experiência, que faz muito, né? Isso é verdade. Mas vocês já fizeram? Eu queria discutir alguns detalhes técnicos para quem não fez e a gente compartilhar a experiência mesmo.
Eu tenho experiência com a transferência.
Eu não tenho experiência também com trapézio inferior. Grande dorsal já participei, mas também não tenho experiência clínica minha, não.
Então, eu coloquei isso aqui, que eu também tenho tempo pouco, a nossa equipe fez alguns casos, alguns detalhes técnicos. Lembrar de deixar o paciente na posição de cadeira de praia, bem para fora, porque no começo é desejável fazer um acesso maior, né, para destacar a inserção do trapézio inferior. A gente não tem banco de tecido fácil no Brasil, né? Em alguns lugares até tem, então a gente retira o semitendinoso, está aí, isso aí foi o R4. Um outro detalhe, então, a gente destaca o trapézio, passa o enxerto pelos dois acessos. Aqui uma pegadinha que tem que tomar cuidado é testar antes de fixar. Porque se você fixa muito lateral e não chega no trapézio, é uma catástrofe, obviamente. E o contrário, se você fixa no trapézio e não chega ao húmero, outra catástrofe não vai funcionar. Nesse caso, infelizmente, nós conseguimos um comprimento bem bom, chegou fácil dos dois lados, deu para caprichar na sutura. Por fim, como a gente amarra, a gente fixa o tendão. E um detalhe também que é difícil no nosso meio, eu acho que no exterior é mais fácil o paciente ter essas órteses especiais para situações especiais, né? O desejável é o paciente ficar com antipóia pelo menos 4 semanas de abdução e rotação externa para diminuir a tensão. Todos nós sabemos que sutura de tendão sob tensão é meio caminho para a falha. E por fim, alguém quer falar? Desculpa.
Eu queria perguntar como é que você fez a fixação do tendão lá na cabeça do humano, por essa via posterior aí?
Assim.
Certo. Mas lá no...
Pode falar?
Na imagem do campo operatório lá, né? Na via, por aquela via posterior ali?
Foi pelo acesso do ombro mesmo.
Ah, tá.
Foi por aqui. Isso aqui é o equivalente ao acesso entre a porção anterior e a média deltoide, só que entre a porção média e posterior.
E posterior, né?
Esse caso especificamente, eu fiz mais posterior do que eu desejava e tive dificuldade para fixar. Você foi super feliz nessa pergunta sua. Se eu tivesse feito mais anterior, teria sido bem mais fácil. Por outro lado, me facilitou o restante da cirurgia. Então, eu fixei com parafuso de interferência, que deu uma fixação super adequada. E tem o pós-operatório aqui. Isso era antes, eu já mostrei, né? Dificuldade de rotação externa, o mesmo sujeito com rotação externa. Parece mágica. Vocês querem comentar alguma coisa, gente? Igual eu falei, a minha experiência é muito pequena também, então eu não quero falar que é a salvação da pátria e tudo, mas nesse caso nós fomos bem felizes.
E a elevação dele voltou normal?
Não, a elevação não ganhou, é porque tem pouco tempo, ele tem uns 6 meses, a elevação dele está com 90 graus. A maior limitação, a maior incapacidade dele era decorrente da falta de rotação externa. Ele está com 90, 100 graus de elevação anterior. Eu gostaria de perguntar para o Jean Kany. Jean Kany, I would like to make a question for you.
Yes.
We have the impression that with latissimus dorsal transfer, we have as a clinical result a tenodesis effect instead of gaining external rotation. What do you think about that? Did you understand it?
Now, could you re-ask me the question? I understand the lat dorsi, but
most of the latissimus dorsal transfer that I performed, I had a tenodesis effect. Instead of gaining external rotation, I realized
okay,
a stabilization only, no?
Okay. So it depends if you want to recover external rotation, like in your clinical case, of course, the lower trapezius, I agree, is really much better. I totally agree with you. My problem with the lat dorsi was in the past the failure because of the rupture of my transfer at the junction between the bone and the tendon. And now I've solved this problem because I've modified the fixation, and now I use both the lat dorsi and the teres major together because it's stronger. I cannot say I have a problem of tenodesis effect. Either it works or it doesn't work, but I cannot say I have a tenodesis effect. No. It's not my feeling.
Okay, thank you very much. Appreciate. O pessoal da mesa quer discutir alguma coisa? Alguém mais perguntar, falar, acrescentar?
Zaca, a gente tem a pergunta do Dr. Ricardo Monteiro, que ele pergunta se a fixação foi over the top ou posterolateral. Como que foi a fixação aí no número?
Ela foi posterolateral. Sabe o que acontece? Quando a gente fala de fixação over the top, foi o que o Kany falou, eles têm banco de tecido, né? O banco de tecido facilita muito. Eles usam o Aquiles e abrem o Aquiles, você consegue cobrir a cabeça toda. A minha ideia nessa cirurgia aqui, e eu não posso falar que talvez seja a coisa mais acertada, era ganhar rotação externa. Então, eu coloquei entre a faceta superior e a faceta média para tentar reproduzir a rotação externa, entendendo que o vetor do trapézio é mais adequado para isso. E funcionou, entendeu? Mas quando você usa... Facelato usa pouco, né? Quando você usa facelato ou o tendão de Aquiles de banco, você consegue cobrir a cabeça toda e talvez aí faça uma restrição mais anatômica. Eu não sei se eu respondi, mas a minha ideia foi essa.
Só observação, o raio-x pós, tu pode mostrar para a gente?
Posso.
Pois é, não parece que a cabeça tenha descido, né? Exatamente isso, o vetor do trapézio ele ajuda muito na rotação lateral, mas ele não desce a cabeça como o latissimus dorsi faz, e aí você não tem o ganho da elevação anterior. Acho que esse é a grande questão de você fazer uma fixação dessa numa perda combinada, não é, Zeca? O que você acha?
Exatamente, foi o Pascal Balot que descreveu inicialmente essa questão, né, na perda de rotação horizontal, vertical e combinada, clear.
Uhum.
Mas
o objetivo foi alcançado. Realmente a rotação lateral melhorou muito, né?
Exatamente, a percepção era essa, que ele estava mais limitado, mais incapacitado por conta da rotação externa. Sim, ficou feliz, né? não tem receita de bolo, né? Lidar com a lesão irreparável no paciente jovem ativo ainda é uma coisa mal resolvida na nossa prática clínica. Não sei se vocês concordam.
Eu tenho uma pergunta a respeito do protocolo de reabilitação. Por quanto tempo esse paciente usou a tipóia como almofada de abdução? Quando foi liberada a mobilidade passiva e ativa?
Ele ficou 4 semanas com a tipóia em abdução e rotação externa, improvisada com colchão casca de ovo daquele, que a gente notou que com de abdução apenas não resolvia nada para rotação interna, pelo contrário. Para ser sincero, ficou muito rudimentar a fixação. Aí depois nós diminuímos a mais 2 semanas com a tipóia simples e começou com a atividade aí de sempre, né? Medida física anti-inflamatória analgésica, ganho de movimento passivo e autopassivo, e depois reforço muscular.
Eu tenho uma pergunta, Zeca. Quando que você toma a decisão, nesses casos de lesão irreparável, por optar ou por fazer a transferência do trapézio ou fazer a transferência do grande dorsal? Assim, qual que é o fator decisório para que você opte por uma ou outra transferência? Já que a gente tem várias discussões aí na literatura, né?
Igual eu falei, a minha prática é pequena, eu imagino que seja igual a da maioria. A minha percepção, que é o que eu falei com o Kany, que o grande dorsal, você não ganha rotação externa. Nos meus casos, que eu fiz, que são poucos, repito, eu consegui um efeito de tenodese. O braço deixava de cair, mas você não ganhava força de rotação externa, entendeu? E talvez ele seja mais adequado para melhorar a elevação, se eu tiver uma perda maior da elevação do que da rotação externa, como foi dito, faz mais sentido isso, entendeu? Por causa do vetor dele também. O latíssimus dorsi também, na nossa casuística mínima, está super mais eficiente em ganhar rotação externa. E, assim, na verdade, o desfecho clínico mais importante é a satisfação do paciente, né? Os casos de tenodese do grande dorsal que eu fiz, os pacientes ficaram satisfeitos. Falaram assim, não, doutor, melhorou, ficou bom, mas a gente não compartilhava da mesma impressão. E do trapézio inferior, fiquei mais satisfeito.
Mais alguma pergunta do pessoal? Nós temos um segundo caso, Zeca?
Eu acho que vale a pena só dar uma perguntada última aí para o Kany, Zeca, e antes de você entrar no segundo caso, para deixar ele um pouquinho mais atuante aí, porque a gente está falando em português, né?
Não foi mal, eu vou falar em inglês, então. Melhor em inglês, né, para ele. Jean Kany, pardon por falar em inglês. Would you like to add anything to this final clinical outcome?
The question is for me,
Yes.
José?
Sorry, the question is for you. We were talking about the difference between latissimus dorsi and trapezius muscle transfer, you know?
Yes, I've understood your answer. And again, about the tenodesis effect, I was thinking in my mind while you were speaking. I think since I am making it fully arthroscopically, I have less, a better excursion of my lat dorsi. It's another point. When you open large, you may have some, not stiffness, but you limit maybe the excursion because of a healing problem or hematoma or something like that. But again, in this situation where the deficit is the external rotation, elbow at the body, the best transfer, I totally agree with you, is the lower trapezius transfer. On the opposite, when the problem is the deficit of elevation or ER2, external rotation in abduction, in that situation, I think the lower trapezius is better.
Okay, thank you very much. And once more, sorry for speaking Portuguese. I will improve now from now on. For our second case, and it's a very common situation, this man, 62 years old, came before me to an emergency hospital, and they did a AP and lateral profile view, and did not diagnose the main disease, I mean. So, Felipe, what is your opinion about the diagnosis?
A gente vê uma luxação posterior, né, do húmero, a gente vê no AP, a gente vê essa sobreposição entre a cabeça e a glenoide, né, mostrando que tem incongruência articular. E no perfil a gente já vê a cabeça posteriorizada e nesse axilar fica claro aí, né, a luxação posterior com a fratura, impacção na cabeça anteriormente, que aparentemente é relativamente grande, né?
And how often does the posterior dislocation is not diagnosed at the first consultant, you know? To say, is it frequent or not, or what do you think about it?
É bem frequente, né? Para os ortopedistas, até os ortopedistas gerais, às vezes passam desapercebidas essas lesões, principalmente por causa da qualidade também de radiografia, né? Os técnicos às vezes fazem radiografias não tão boas e aí passa bem desapercebido. Mas realmente o exame clínico é preponderante, a pessoa fazendo a rotação externa aí vai ver que não consegue fazer e diagnostica às vezes só no exame clínico, né?
Yeah, perfect. And the loss of external rotation is pathognomonic of this disease. And Rodrigo, do you think we need additional exam propedeutic or not? It's okay with the X-ray.
Não, a tomografia sempre necessária. Fraturas articulares, né? A recomendação que a gente usa é a tomografia para, enfim, identificar melhor a lesão, classificar, programar melhor o tratamento. Então, nesses casos, com certeza a tomografia está indicada.
Moçada, se vocês se sentirem vontade para falar inglês, é bom que o Jean Kany participe. Desculpa, foi culpa minha começar em português.
Tudo bem.
What do you consider? What are the main, how can I say, the main parameters to be studied in the CT? Come on, Rodrigo.
Okay, I think it's important to look for how much of the head is compromised, because if you have a big compromission of the head, probably you will need arthroplasty and not repair and fixation.
Sérgio, specifically for this case, what would you recommend us to do?
Olha, esses casos aparecem comum aqui também no nosso serviço. Primeiramente aí, eu faria a cirurgia de McLaurin, né? Transferir essa parte da tuberosidade menor e fecharia esse parte desse buraco. Manteria o paciente. Aqui a gente não consegue manter só com a tipoia, né, normal, a gente botaria com a de abdução, tentando manter a rotação externa. E essa transferência da tuberosidade menor, ele acaba evoluindo bem, né? Agora, o importante também é ver que na hora da cirurgia, como estaria a cabeça, né? Se a cabeça humeral já estivesse meio necrosada como bola de ping-pong, também aquela cabeça meio mole, é bom estar com a prótese na sala, né? Mas eu faria a McLaurin primeiro.
It's just a few days dislocation, so you expect to find a normal articular surface, okay?
Okay.
Mr. Kany, do you have any special consideration? How often do you face this kind of cases in Toulouse?
How many times? One case every 5 years. So I remember 3 patients like that in my life. So I made surgery, of course, but it's very rare for us.
Thankfully, it's a very rare situation. But as Sergio told us, he would rather to do the McLaughlin procedure, you know, of course, you know. Do you think, is it worthwhile to try closed reduction or not?
Sorry?
I mean, is it worthwhile trying closed reduction or not? You go direct to the open surgery.
The question is for who, Jose? For me or for Sergio?
For you at first.
For me first, I will never try. I will not try a close reduction because I would be afraid of making a split fracture, because I've seen that if you try a close reduction, you may have cut the head totally and the hand is behind, and And so I will try an open reduction with yes, a McLaughlin procedure probably, and maybe an NE prosthesis, but it depends on open.
Bingo. Perhaps it's the most dangerous complication in this case is trying to do external rotation. You do an anatomic neck fracture, it's a catastrophic result, of course. Very good remembering that. So let's go on. Conductor have already talked about that. This is the surgery. Philippe, can you comment for us, please, the McLaughlin procedure, any special tricks that you have to do? Because as long as you have a big hole with impacted cancellous bone, it's difficult to know the anatomic parameters in the humerus head. Yeah. So tell us how you do that.
Yeah. The McLaughlin, I perform the modification of near, and I usually cut a small bit of the neck of the lesser tuberosity and transfer to the fail in the head, and then we fix usually with screws from anterior to posterior, and also complement with a suture of the subscapular. It can be with an anchor or like this we have done.
Okay, great. Thank you very much. Sérgio e todos vocês fixariam de uma forma diferente? Uma dificuldade que o pessoal tem no começo, quando eles fazem os primeiros casos, sorry, once more. Would you consider fixing it in another way? And one difficulty for the beginning surgeon is where to fix it, the tendon and the tip of bone. So, Sérgio, what do you do to fix it? Would you fix it in the same way or different?
Olha, eu fixo a tuberosidade menor geralmente com 2 parafusos, entendeu? Eu tiro uma parte considerável dela. Acaba que aqui no serviço a gente não usa essa parte de âncora e eu fixo ela praticamente nessa posição mesmo, parafuso. Agora eu fixo com 2 parafusos.
Okay, thank you very much. And Mr. Kany, do you fix it in the same way, or would you consider another way to fix it?
Yes, I would fix it in the same way. I believe a lot with anchors, and maybe I would made a double row system anchor, and maybe the screw is not really useful because the bone is fragmented, and the washer, and it's not very strong. So I think screws alone probably are a mistake, and it's mandatory for me to use an osteo suture with many anchors like you did.
Okay, Oi.
Oh, desculpa, pode falar, desculpa.
Pode falar.
Não, nós temos a pergunta do Maurício Raffaelli. We have a question about Maurício Raffaelli. Anybody make a reverse repensage for arthroscopy?
Perdão, falhou, não entendi. Eu queria mandar um abraço para o Maurício Raffaelli.
Se faria uma reprissagem reversa por artroscopia nesse caso aí?
Pois é, eu acho que é bem factível. Eu nunca fiz, não, sabe? Tecnicamente, eu acho que não deve ser a coisa mais difícil do mundo. O problema, para quem já teve a oportunidade de operar a fratura dos tubérculos por artroscopia, que, na maioria dos casos, a anatomia não está tão distorcida, é muito difícil de você conseguir reparar bem. Trazer o pedaço de osso que geralmente é multifragmentado e no subescapular que é muito forte, eu acho que deve ser complicado também. E a gente volta para o meu problema, que é a questão da redução fechada.
Zega, posso dar só um comentário sobre isso, sobre o reverse replissage? I have some experience with this procedure. I usually do it under scope, but in this case we have a lesser tuberosity fracture already, so it's not good to do it using the scope.
Mais ou menos o que eu estava querendo dizer, você foi mais assertivo. Alguém quer perguntar alguma coisa mais?
Nós temos outra pergunta do Bernardo Terra, dando os parabéns ao Zeca pelos casos e considerando um paciente jovem com uma luxação posterior com menos de 10 dias, como você veria a manipulação sob anestesia e a tentativa de redução fechada, evitando rotação lateral? E se você se preocuparia com uma lesão labral posterior, e ele reforçou a questão que já foi falada aqui do McLaughlin artroscópico.
Bom, vamos traduzir, né? Jean Kany, they were asking me if I consider closer reduction and mobilization, first of all, and after that, if there is a concern about the posterior labral tear, and what else? The final question was?
If you make a manipulation for the anesthesia.
Posterior labral associated lesion.
Okay. So my answer is I did it twice, closer reduction and mobilization external rotation splint. It did not work. Okay. As the literature says, we are supposed to try under 20% of the surface to try close the reduction between 20 and 40%. This is what I've done, and more than 40% the arthroplasty, okay? That's what I did. I did it twice, closer reduction, did not work. My personal opinion that the main cause of instability is not the ligament, is the bone loss, so I did not worry about the posterior ligament, and it worked fine, as you can see here. This is the final result about 8 months after surgery. Is there any question left?
Acho que não. Zeca, antes de tudo, agradecer a sua disponibilidade, né? Agradecer os casos que você trouxe, agradecer aos colegas que estiveram presentes com a gente na mesa. Eu acho que foi um momento de troca de dados, informação, né, de experiência. Gostaria de agradecer a todos que compõem essa regional, né, e que nos apoiam em todas essas ações aí, a nossa sociedade, a SBCOC, na pessoa do Luiz, né, Fábio Brandão, do João, que nos tem apoiado muito, e apoiar todos os colegas da nossa regional que têm feito presença e permanecido até o final. E gostaríamos de agradecer ao Dr. Kany pela presença. Dr. Kany, thank you very much for your attention, for your discuss. It's a great, thank you. E pedir para que Luiz, que representa a nossa sociedade, a SBCOC, e Fábio, nosso ex-presidente, os agradecimentos finais. Passo a palavra, Luiz e Fábio.
Eu acho que vale a pena a gente se despedir do Kany, todos nós aqui presentes, João, Fábio, Zeca, os debatedores, e aí a gente pode falar só em português, que eu acho um pouco deselegante a gente estar falando em português, ele sem entender. Professor Kany,
yes.
It was an honor to have you here. Your presentation was great. We learned a lot with you. It's a real pleasure to have you with us. Please, you're welcome all time with us. Please come in physical manner.
Okay.
Maybe this year, who knows, on December in Recife, to do some transfer procedures, who knows. And please feel free to say your last words. But before you say, other guys want to tell something.
Yeah, thank you very much once again to be with us in this Saturday. It was a great honor, a great pleasure to enjoy your company today. You know, Neymar may be a superstar in France, but you are a superstar here in Brazil. So thank you very much. I hope you see you here.
Merci beaucoup.
João.
Yes.
Dr. Kany, thank you again in the name of our group of Northwest Shoulder and Elbow Society. It's a pleasure. And I don't know to have another words. It's great for us to stay with you during this morning. Thank you very much.
Thank you. Thank you.
Zeca.
Fala, eu.
Feel free to speak in French too, you know.
En français.
Ça a été super, votre présentation. Félicitations. Et avec plaisir de parler avec vous. Ça a été enchanté avec votre mot. J'ai fait beaucoup de questions avant, en cas les gens ne font pas de questions pour vous. Et pendant votre présentation, vous avez déjà répondu toutes les questions que j'ai pensées. Alors, félicitations. Merci beaucoup pour votre présentation.
Great.
Merci.
Sérgio Cabral.
Dr. Kany, thank you very much. It was a great presentation. It was a pleasure to be here to see your presentation.
Thank you, Sergio.
Thank you so much to everybody, and Dr. Jean Kany. You are welcome always. Thank you.
Okay, thank you.
Rodrigo.
It was a pleasure too. It's very good to be here with the best shoulder and elbow surgeons from Brazil and from France, and why not from the world. Thank you very much, Jean Kany.
Please, Jean, it's up to you.
Okay, so thank you everybody for your very kind invitation. Again, it's an honor for me to share. And of course, you're right, the goal is the virtuality business contact is good and magic somewhere. And it's very easy to take a flight now and to see you and to come back to home. But the goal is to meet together face to face and to eat some good steak with you and to drink some wine too. Coming from a country. I hope coming back soon. Thank you very much.
Thank you. Thank you very much.
Thank you very much, Dr. Kany. Obrigado a todos. Bom dia, bom sábado, bom final de semana.
Bye bye. Tchau, tchau.
Um abraço, gente. Obrigado.